You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Welcome back. Week in Review, episode 31. We're missing the smallest man in the world, Seth Graham. No, he's not. He's the smallest man in the office. So it's just me and Alex running down two cases. What's your case? Give him a one sentence overview.
Flexion avoidant. I don't.
Dude. Flexion avoidant dude. And mine is a year-old femur fracture and a 15-year-old track and field athlete and kind of the ramifications of, what happened. So besides that, I don't think there's any house cleaning to take care of other than Alex is going to make sure that he's up on that mic today so you can hear his songbird of a voice. And then if we have, we got one of our faves, Kaylee.
Dr. Fetzko.
Since we have some people, we will try, since we haven't had a lot of post Q&A, I haven't had a what we call Barnyard Banner episode where we do that behind the paywall for those residency members, but hopefully we do today. We'll see what happens. So I'm going to have, that was a drum roll. You're up first. Yeah. So roll.
All righty. So we have a 25-year-old firefighter, and
this is a dude guy.
Yes. Guy. Yeah. He's like 6'4". 6'4", about 160.
What's he identify as though?
A firefighter. That's my
my 3-year-old daughter would identify as a dinosaur sometimes.
Yeah.
So, I don't know.
A fireman, not a firewoman.
Okay.
But he has been dealing with low back pain for, at this point, it had been 3 years, 2-3 years. Had previously been diagnosed with a disc herniation in his lumbar spine, and
via imaging.
Yes.
Yeah.
At this point, he was just starting to get into firefighting, and he was doing, the body drags where you have like a dummy. And he was bent over pulling one and felt it pop.
That's how I made money in undergrad.
Yeah, body drags.
I was the dummy.
Oh, the dummy. He felt that pop, had ridiculous symptoms down his leg. And so he was seeing a practitioner, another chiro for that, and responded really well to lumbar extension, McKenzie extension, centralizes pain. He's doing good.
Mm-hmm.
Finished that trial of care, and then I'm seeing him at this point 2 years after that, and he's describing pain, but not actually happening. It's more of I'm worried that if I do this thing, it's gonna hurt. And he tells me all of this, and that he's continued doing his press ups.
And this is how long now that he's been doing these? 2
years.
Like how often are we talking about?
Homeboy's rocking out press ups every day.
Just in the morning or like throughout the day?
Probably throughout the day.
Cool.
And
that in Rich Olm terms, that's called playing with your derangement.
Playing with your derangement.
Yeah, playing with their derangements.
Yeah. So, and now whether that was the practitioner telling him that or not,
right.
he just assumed this probably helped me before, so I'm gonna keep doing it. He also, in that time period, got really big into jujitsu. Or I guess at the time he was seeing that clinician, he was getting into jujitsu and really, really enjoyed it. So he hadn't been able to compete or to practice at anything, because he had a few flare-ups whenever he would try to get back to it prior to seeing me.
But he's still able to work,
Yeah, he's still been working. He's still been working as a firefighter.
Does that not worry anybody that they don't have any kind of clearance test? So this guy is not willing to go to jiu-jitsu yet. If my house is on fire, this guy's going to have to unravel a hose, carry it, maybe carry me out as the dummy. He might not be able to because his back hurts. Which, they don't have any screening.
Yeah. And not saying he's not a strong dude, but 6'4", 160 is not the biggest person.
Hey, Aaron, mute your mic if you can, bud.
We love you. We don't want to hear any babies crying.
But no, isn't that crazy?
Yeah.
I don't know. It just blows my mind. Mm-hmm. Which, again, we always talk about in here. The biggest body of movement data came from FMS, right? On firefighters.
Oh, yeah.
and we had this, well, quick side story if you don't mind.
Mhm.
The chief of the Cabo Valley Fire Department came to me because he was a patient for a long time and said, "Hey, I love what you guys do. Is there any kind of like," he had no clue this exists with FMS. Is there any kind of like movement assessment you could do for our firefighters to help kind of offset injuries? Because people just like get hurt. And I was like, dude, here's this piece of literature. Like, I mean, this is, FMS provides this if you're an FMS member. He presented it to the overall overarching chief of the greater, I don't know what it's called. It's not Shelby County. I don't know what it is.
The Federation of Firefighters, the
Yeah.
Triple F.
Yeah. It was basically Trump. I just figured he would be a, Star Force or whatever he wanted to start, and firefighters.
Yeah.
He presents it to him. We show the cost savings that they had, which was thousands of dollars. All we were going to charge these guys was like $25 a piece for each firefighter. Nah, we don't want to do that. It was insane. Like, we were going to save them all of this money at a nominal cost and not even asking them to come in. Just do this assessment, do whatever we give you. If you need us, we're here. Nope. So it does exist. They just didn't want to do it. Okay, back to the case.
All righty. So he had been hadn't been to jiu-jitsu since July of 23. I'm seeing him now in December of 23.
Got it.
So it's 5 months or so.
Mhm.
Which you could tell that was like really getting
Had
him
him down.
He wished that he could be there. And so I'm asking him again, are any things at your work creating any of your pain? And he said, no, but I feel like if I go into that situation where I have to drag a body, that it's going to create pain. He's also been wearing lidocaine patches every day out of fear that his back is going to bother him again. Hasn't been able to sleep on his side because that's created low back pain in the past.
Doesn't know if it
does it now.
So you're taking this history without taking and short of yellow flag questionnaire. We talk a lot in the office now about this like spectrum of where do people lie, right? It's not like, oh, it's, chronic pain. Oh, this is musculoskeletal pathoanatomical. It's like a spectrum. Where on the spectrum, love on the spectrum style for the injury, where is this guy in your mind already?
Yeah. If I'm looking at Seth's chart in my head,
Yeah,
it's like all the way to the left. So all the way to the right is injury.
Musculoskeletal.
Tissue, yeah. The other side being central nervous system driven.
So you think there's very little pathoanatomical, structural
at this point? Yes.
Yeah, at this point, yeah.
At this point, even though previously it had
right,
true signs of
scenario.
radiculopathy. Yeah. So we start going through exam. First day, dysfunctional non-painfuls are multi-segmental flexion, which is the pretty much only thing, and that's because he cannot flex his low back. He goes down into flexion, and his thoracic spine's like this, and his low back is super flat.
And for those who are just joining, this guy's been doing extensions multiple times throughout the day for the past 2 years.
Yes.
Because he got left.
Because he had a previous radiculopathy that resolved with that. And
whether he was told or not, we don't know to do that, but I don't know.
Yeah. He kept on keeping on.
How was his multi-segmental extension?
Oh, he had it. He had it all day. Now it's probably not segmentally shared now because his thoracic spine. Only other things, deep squat and right upper extremity pattern 1, which was from a previous shoulder injury, I think, growing up. Okay. Orthos, nothing recreates pain. Slump is incredibly tight for obvious reasons, and that's on both sides. Like he can't even really fully extend his leg. Normal neuro, T-spine extension restriction, lumbar spine flexion restriction.
So it's basically like a 75-year-old guy.
Yeah, but 25.
Yeah.
And he's got really hypertonic lumbar spine erectors for, again, obvious reasons. So the first day, all that we did was breathing in child's pose. And then when we spent a lot of time there, just trying to get him to round his back, low back, and show him that he can round his low back. It's not going to create pain. Then took him through some segmental cat-cow in that, well, I guess you'd say lowered
Low.
cat-cow,
Yeah.
to try to move his lumbar spine.
Yeah.
To see if he could even do it, because his ability to create flexion was really hard. I doubted he could move his spine into flexion, which, yeah, it was tough. But we get up, have him check slumps again, and he goes, dude, that's totally different. Which
quick note, I love that you and Seth, maybe other students, call it slumps.
what do you call it?
Slump test.
Oh,
I don't call it slumps. Like,
you got a bad case of the slumps.
you guys always realize like, yeah, slumps was negative. I'm like,
it wasn't a guy, I know. It's just like, yeah, I think about it as being,
yeah. I don't know. It's like scours. I don't know.
Yeah.
Scours. I don't know.
Yeah, that's fair.
It's just interesting. It's
But
funny.
slumps felt
Don't change
good.
it. Don't change it on my behalf. I just think it's funny.
I've literally never thought about it. But yeah, he got into that position, slumps, and it felt great. He said, wow, that's incredibly different. I don't remember if he touched his toes, but he was really close after that.
So
at that
big
point.
difference movement wise.
Yeah.
Yeah.
And then I told him, I said,
And that was painful before, or just
No, it was just
functional painful.
he had nothing that was painful.
Right. Okay.
But what I told him was that I said, it's been long enough that this has actually created tissue change that we have to try to change.
Yeah.
It's not, if this would have been in a shorter amount of time, I bet that would have cleared up entirely. You would have palmed the floor and been totally different. But that's what the cards we have right now. So what we're going to do is teach you how to create flexion through your low back and show you that it's safe and stepwise manner so that he doesn't flare up and think that this is going to be really bad. Which part of that is getting him back to jiu-jitsu, because I know that's what he wants to do, but he also, second goal.
Think how much spinal flexion is needed for jiu-jitsu.
Yeah, exactly.
Guard.
Which is why I was like, we gotta get this back.
Yeah.
And then the other part being able to do his responsibilities as a firefighter without worrying that he's gonna mess himself up.
That's wild.
Yep. So that was all day one. Let's go next visit. Actually, Seth saw him the next visit because I was in LA hanging out with that guy. We were getting coffee. I think this was actually that day, or maybe the day after. But comes back, Seth reports no back pain, sore and stiff after driving. Exercises have helped him feel not as stiff when he wakes up in the morning. I also think I forgot to tell Seth about the lidocaine patch thing, because I was like, we'll address that later. I just had it had been a long visit, and I was like, well, we'll get to that at some point. Let's see, did he do anything different? Seth did some Jefferson curls with him that day, because Seth and I had talked prior to him seeing this patient, and he said, is there anything that I should avoid? I said, no, like do something hard. And this guy has no prior history of weightlifting or doing anything of that sort. And he goes, I don't deadlift, but I feel like if I did it, it would be bad. And so I said, okay, well, one of your goals is going to be, we're going to deadlift. Because he said, I want to do weightlifting things. I feel like it would help with jujitsu. But I'm afraid that, one, I've never been shown how to do a deadlift. Two, especially with my back pain history, it's going to be.
Isn't that also crazy that there's no like weight standard that you got to be able to, just like the military, I mean, it's not a great physical entrance test now, but like if you had to carry somebody, which
I know in the higher ranks they are, like my buddies that were in
100%,
like EOD and stuff like that. They had,
now they're starting to use CrossFit standards with like PT stuff. That's, my brother-in-law's high in the army, and they have certain like deadlift markers and stuff like that, because they're supposed to mimic. Just interesting. I mean, literally like a life-saving thing, which means that like his life is in danger if he can't do it. Right? Like you got to try to pull somebody out, and now you're both.
And he's probably in better shape than most of the people there.
It's just wild. That's so crazy. I'm never calling the fire department. Just use a garden hose or something.
Go get the bucket.
Yeah. Claim the insurance.
A little rascal
get the kids out. Claim the insurance. Yeah.
All right. So visit 3. I'm back. Jet lagged from the longest flight I've ever been on, which is not that long compared to most people. But so kind of the same thing. Morning stiffness is getting better.
Whoa, you need to say that different.
Yeah. I almost pulled a Bridget.
His low back being stiff.
He's 25. He's 25. He really liked the Jefferson curls, so he actually went to the gym and did those. And he said, it felt like I was working out, doing stuff in the gym, which was a big, kudos to Seth for getting him to do something in the gym where he felt like he was working out, which was a goal to get us back to. And he's eager to get back to lifting and jujitsu. So, did we do anything different this day? I think we discussed the lidocaine benches.
Which is funny because just how much dissociation between just feeling his back.
Yeah.
Right.
Yeah.
And then
creating numbness.
Yeah.
I put him into start position to start working on T-spine extension with lumbar spine flexion because that's actually stiff.
Which is like such a theme. Like I was working on that with somebody today. My wife sees a bunch of gymnasts. Like we've talked exclusively about that on previous podcasts. One of the hardest things, because gymnasts are taught to hyperflex their thoracic spine for this massive hollow. And they literally now, she's seeing compression fractures at mid T-spine on the anterior portion of the vertebrae. They're literally just like crushing their back to be able to, which is, so you still see spondylos, but then you see that. It's just kind of interesting that we work on that.
Not good.
Stenotic patients, this guy, gymnasts, it's just like a recurring theme. Like your low back don't flex and your mid T-spine don't extend. Just keep going. Let's keep going.
Yeah. Okay. So this is visit. Where do we have? 5, 4 now. And he comes back in this day and he's like, all right, man, I can see that he's worried. I said, all right, man, I think I might have taken some steps back. I said, well, what happened? He said,
I slept on my side.
I forgot last visit. I said, hey, I want you to go to jujitsu and try something, right? Not a full practice. His main thing with that was wanting to be able to get back to do a roll. And so I said, do a very scaled back version, maybe just spar with somebody, just one person for a short amount of time. And he said he was trying to show someone how to escape from a triangle choke on his back. And while he was doing that, he felt a twinge in his back that lasted for a day and a half. No radicular symptoms, but was provoked with sneezing and coughing, which was something on his original when he had the radiculopathy. And again, worried he messed himself up, but has no issues with Jefferson curls or breathing after doing that.
That's called a limbic response.
Yeah. And he went immediately to those. He said the next day I went to the gym, I did my Jefferson curls and I did some breathing and I felt good. I said, my man, that's what you got to do. So we talked him through that and how progression is not always linear and you're going to have little peaks and valleys and that's okay. So that day I put him through a reverse curl up, down. Like if he was holding on to TRX straps, lowering himself down segmentally, thinking sacrum up to lumbar spine. And we coupled that with a deadlift ISO. So I had him in the bottom of a deadlift, elevated up on the platform, holding a kettlebell and trying to get him to elongate T-spine while flattening or flexing lumbar spine, all around good intra-abdominal pressure. I don't think I sent him home with either of those things, but we did it in the visit that day. Then next visit, we revisited the deadlift ISO. We're kind of mainly working on that part of his movement now because he wants to get back to doing a deadlift, which he's been doing with a Jefferson curl, just different, right? I'm not going to have him go load 135 pounds on a Jefferson curl.
Are you going to have him drag that 130-pound sandbag around the gym though?
I should do that,
off
man.
a rope.
Yeah.
I would.
That's a good point. I ain't seen him in a while, but I should do that. Then at this part also, I had him say like, hey, let's go try more things at practice, doing longer duration, multiple bouts of, I don't know what they would call it, just engagement. I don't know. I don't know what you call it.
Just rolling in general.
Rolling in general.
Which escaping a triangle is also climbing somebody with your feet. Like if you're in guard.
Yeah.
So like massive amounts of flexion. Imagine if you had me on the ground, I put my feet up on your shoulders and then pushed. It's like we could see why that one instance, like, yeah, you haven't done anything like that in
Long
2
time.
years.
Long time. Well, he had been back to jiu-jitsu some on and off.
Wasn't doing
but
much.
yes. And he said so this visit, 5, 6, wherever we're at, previously he had done a roll at practice and had no pain, which was a big win for him. He was like, emphatic when he told me that. I said, there you go, man. Still feels like the Jefferson curls are really helpful. And he started doing them from a deficit at home. I was like, all right, man,
Gotta love it.
here we go.
You know he's gonna go overboard. He did extension for 2 years. You guys are like,
Now
okay,
he's
well,
gonna be flexion
go
king.
do regular deadlifts instead of deficit Jefferson curls. Yeah.
Oh, so at this point, I was also the main thing that we did in the visit that day, as his goal was to get in and start creating a weightlifting routine for himself. I said, all right, so we've already been working on the hinging, so let's start working on squatting, lunging.
Mhm.
And instead of just having him do a squat, I said, let's go through a split squat, reverse lunge, and see if we can create the same stacking of rib cage over pelvis, creating good intra-abdominal pressure while he's doing that. And so that went really well. I had him try those in his workout routine when he goes to the gym.
Which a big thing that we do in particular with stenotic patients, it's not like there's kind of playbooks for certain things. TMJ, stenosis, like there's kind of a playbook. Stenosis, we just find ourselves, you early phase flexion with most people, then you have to introduce T-spine extension, then you have to introduce lumbar extension. And what we try to work in early is like overhead carries, right? That's a big one because now you have to get into T-spine extension. Your lumbar spine hopefully is not overly extended. You have to move through mild hip extension. Then we try to work in overhead lunges. And like these are the killers of stenosis. Like it'll drive symptoms wild if you're not at that stage yet. But it is also like if you can get people to do that, that's that last abolishment of the people that walk for 20, 30 minutes, like, oh God, I have to go bend over a park bench. Because now they're, from a neurodynamic standpoint, having to go through hip extension while they're, in this length and T-spine extension and not letting themselves just go into flexion. So same thing, like, again, not a protocol. But when you see this lack of lumbar flexion, lack of T-spine extension, you kind of have to then build the whole pattern into one thing and load it and continue to do that over and over and over.
Yeah. So his last visit that I've seen him, things got spaced out a little bit because he was actually scheduled that day that we had the ice.
Yeah.
So that ended up with work pushing him out.
When it gets below 30 degrees in Alabama, everything shuts down.
Yeah. To be fair, the roads did freeze. And we still showed up.
We were here.
So he reports that he was able to, there was a guy that showed up at the gym that he was friends with, but, or at the jiu-jitsu, what do you call it? Dojo?
Gym.
Yeah.
Jiu-jitsu gym, dojo, I don't know.
But he fights MMA. And so the guy's reputable around the gym. He's pretty good. And he asked him if he could just
roll with him.
Yeah. So he said, all right. And he said, not only did I not run out of time, but I landed hits. So normally people run out of time with him or they don't land any hits. And he said it was a big confidence.
If you can tell, Alex knows nothing about MMA.
Yeah, I don't know.
So he's talking about jiu-jitsu, but landing hits. So we don't know if he's grappling or if he's striking.
He should do whatever the heck he wants
he could have got the shit beat out of him. We have no clue if this guy's what's happening to him in the jiu-jitsu gym, but
I think
he's okay. In our office, he's okay.
Yeah, I think they actually showed up with those Teenage Mutant Ninja Turtle backpacks.
Yes.
And just fought and occasionally took swords out, which
probably
hits.
It's probably just a big pillow fight gym.
It might be. It might be.
Yeah.
So that was really good to hear from him. And I didn't change anything of what he did at home. We again went back and looked to make sure the deadlift and the split squat and everything looked good.
Perfect.
So
cool.
I think that was 7 visits.
Yeah.
7 visits.
Do you have another one on the books, like a check-in or anything, or you just kind of
hopefully?
Yeah.
Yeah. Well, it's not till the first week of March.
Yeah.
So I think it was like 6 weeks.
Give him time. Yeah. Do all these things, check back in.
Yeah. Because that was the end of January.
Yeah. Any questions from everybody joining us on Alex's case before we hop over to mine, just so if anything's like fresh in your minds, we're not waiting until the end. Dun, dun, dun.
Okay.
Yeah.
How do you have that conversation with someone when you think they are just, with all due respect, more of a head case, like a fear avoidant case?
Mm-hmm.
How do you kind of talk them into like, you can do this thing. This is all your mindset.
Yep. Initially I had to show him, which what we showed the first visit was that slumps that he was really tight in, he could tell. He said, that does not feel good. And so I went back to that after we put him into flexion. without him really knowing he was in flexion, create pressure, get done. And that's really different. Then he was able to see, oh, I can do that. And it doesn't create pain where I would have thought previously it would have created pain. Same thing with him bending down, touch his toes, because that was something that he avoided doing, was touching his toes. Over the course of the visits, the first couple, I guess, gradually increasing the thing that I was showing him would have probably hurt him before. And reassuring him while we were doing that, hey, this is going to expose your back to something that you haven't done in a while. You might be sore from it, but it's not going to hurt you in any kind of way.
Yeah. Yeah. I think and then in my opinion, in our clinic, we don't want to just graded exposure, show them what they think they couldn't do. The explanation to back it up is, I think, wildly important. So they're not just like, because if you don't explain it, so if Alex does all, he's like, oh, it does feel better in flexion. He goes to jujitsu gym, hurts his back. There's no way he can go and doing Jefferson curls the next day.
Yeah.
Right. Because he didn't have the framework behind it, even though he'd be like, yeah, I felt better. And then he'll come back and do what? What happened? Versus, I kind of understood what you're telling me. So yeah, it's both, but I would never start with the explanation. Like I had literally a 70-year-old woman with stenotic pain the other day that told me the worst thing she could do is pick up 10 to 15 pounds. Second visit, we had her deadlift a 20-pound kettlebell. Didn't tell her how much it weighed, right? Just kind of worked through. She had I barely had to teach her how to hinge. She just had it down. I knew it was going to be great. And then I told her how much it was. She goes, can I do it again? I'm like, yeah, sure. And then we had her doing Jefferson curls deficit with 15 pounds the other day. And she'd be like, oh, my back's kind of sore. I was like, cool. It's never moved like that. Like maybe never. Yeah. I don't know. You're getting up there in age. But yeah, I would never just be like, hey, listen, and then go do all this stuff, because she's going to be like, what are you talking about? So it's pretty cool because she's super competitive. So she's like, can I do this? Can I do that? So yeah, I'd say perfect answer from Alex, like show them and then explain.
And explaining the expected lengthier timeline a little bit of the fact that he has stiffness against 2 years of putting himself into extension.
Purely neurologic, which also sets up the time frame for your treatment plan. It is very different. Like even if somebody just did extensions for 2 weeks and they're like, hey, I'm on the other end of this, which can happen for sure. Yeah, I think that's a really good point, which Rich talked a lot about at the DNS manual therapy course, of like making sure you preface like, you've had tissue adaptation versus we're doing some motor control neurologic switch. Otherwise, like the expectation is wildly different, both from the practitioner and the patient. You set them up for a fail, you got tissue change, and they've heard from everybody that told them to come in that, ooh, Alex got me better in 2 to 3 visits.
Yeah. You're not going to
2 years. Come on.
Yeah.
Like, we don't necessarily have a crystal ball and can tell you how long it's going to take. It's going to take longer than 3 to 4 visits.
And changing his pattern is tough because he really has to think about what he's doing in a deadlift and a squat, because his default is to excessively round his thoracic spine, leave his lumbar spine and extend, even if he tries to create pressure on top of it.
Yeah.
And I had a hard time while I was going through a couple of those visits explaining to him how to cue it differently without being super
in depth.
Like I could tell sometimes I was word vomiting and I was like, you got to stop. You're doing way too much. He's trying to think about all this and he's messing himself up. Like,
but that's where you need, like, well, I'll give the example. I had another patient that I was working on with I just saw her today again on mid T-spine extension, like just getting her, she's 45. And I was doing all these, DNS stuff, and someone goes, well, hey, with my gymnast, I basically just get him into a lumbar lock position. Instead of doing rotation, I just do extension from there. I was like, Jesus Christ, why did I just do that? Like, that's so much easier than all the stuff I was doing. And I was like, that's a really good idea. And then next time we did it, she was like, yeah, that's really hard to do. I was like, but she could feel her back. I was like, cool, go home and do that. So that's where, like,
times too.
Fundamentally break it down to the most simple thing, but you also need a bag of tricks. You need 15 different ways to teach somebody to feel their mid T-spine. Right.
Yeah.
15 ways to get somebody to flex their lumbar spine. And that's experience, because you just see stuff, right? A lot of different ways to do it, but also playing around. Like the biggest thing with motor control stuff is flipping positions and flipping bases of support. Right. You change how they're supporting their body, and all of a sudden something that was exacerbating symptoms or inability to do happens. that gives you a perfect opportunity to explain like, oh, look, you could do it here. You couldn't do it there. That's a mismatch. But also you have to figure out how to do that stuff. And sometimes it takes like, I mean, with Alex, we did a drill the other day. He goes, oh, I wouldn't thought of that. It was for him. Like we were doing it. And he's like, oh, yeah, it's a good way to eccentrically load your tricep. Like, yeah, just one little tweak. So that's just being creative, being playful, I guess. Yeah. Mm-hmm. Any other questions on Alex's case? I like that.
Did you talk about it with him with just programming his workouts in general, so he doesn't just go and do a million Jefferson curls and create a new for himself?
Yeah, he pretty much does. Well, he only goes to the gym probably 2 days a week, 3 days a week. So he does them when he's there, which I'm fine with him doing Jefferson curls 2 or 3 days a week. But I was trying to give him some more options of things to do because he's been doing push-ups and pull-ups and he's always done upper body things. But that's why I was trying to include more options for his entire body by incorporating hinging, the split squats, and reverse lunges.
No. Cool. All right, let's jump to the next case. And if we have more questions, let's go at the end just so we don't like burn too much time. Okay, so this is it's a good segue from talking about this kind of like fear avoidance behavior, kind of moving around stuff, because this case is a little bit different, but kind of plays in the same vein. That this is a 15-year-old female that she only does track and field now. She had a previous background in gymnastics and tumbling. So that gives us a profile idea of what we're dealing with. And she is a sprinter and hurdler. In January of 2023, she caught her trail leg on a hurdle and had a spiral fracture of her femur. Gnarly. And that's exactly how I fractured my femur, not on a hurdle, but my leg getting pulled behind me, and then your femur just gets whacked. So I can commiserate with her. I was a couple of years younger than her, but kind of same thing. She underwent internal fixation. So she had a rod and they just did proximal screws. So she has 3 screws proximal, none distal. Her mom had to ask for physical therapy. They were just going to let her roll. So this is not uncommon when you do these internal fixations, whether that's lumbar spine fusion, intermedullary rod, that they're just like, oh, you'll be good. We made your bone. Your bone's better. You'll be fine. So she did PT. She exited surgery at the beginning of February, did PT until October of 2023. Okay. And then she got a full green light, go back to, this is now getting into indoor season. Go back to track and field, get after it. We've done all the return to play criteria. You're good to go. Like I said, she's a sprinter, so she's kind of focused on the 60, and she's kind of, you could tell, nervous to jump because she wants to do long jump. She hadn't got back to hurdles, but she said she would try, which I was like, yeah, I think you need to, just from a fear, like get back on the horse type deal, which I'm being honest, I would be very fearful of if I caught my leg and fractured my femur.
Because they get caught all the time.
Yeah, I was like, you need to do it. Freak injury. Now, what she's dealing with now is only when she runs at top speed is she's having anterior hip pain, like right at the proximal, kind of tendon, like rec fem area. Only when she runs fast, and it kind of lasts. Like if she does a workout with intervals and stuff, she'll have pain like that evening. She wakes up the next morning, she's sore, and then it goes away. Like she's fine by the next time practice shows up. If she runs slow, which is not common for her because she's a sprinter, nothing at all. Only other time she feels it is sitting cross-legged, like crisscross applesauce, Indian style if you're from the 80s. So that's it, right? No treatment for this at all. So she got cleared from PT in October, got back to indoor. She started running. She's had pain the whole time, and she's said it's like a 7 out of 10. But she doesn't feel like it necessarily affects her gait, and it's not making her have to quit practice ever. So my kind of general presentation, like I said, she was in gymnastics, tumbling. So she's kind of a little stockier, a little more muscular, healthy girl. So I like knowing those phenotypes because that's very different than saying the spindly, super skinny 15-year-old girl, right? Just from a profile. Top tier moves like a gym, all functional, non-painful on top tier. So then immediately I'm seeing what? She's telling me it's only running at top speed and she just moved awesome. When I'll skip one ahead. Nothing major on her gait analysis other than her right glute is a little bit concave. That could be how her glute developed through her life. It could be that she's in this concentric glute. I haven't had her on the table. I have no clue what it feels like. So that's the only thing I noticed. But then I was like, right away, because we always talk about an art of assessment, like you'd basically do a history, you would do a gait analysis, and then usually before top tier, you're going to do some sort of specific movement testing that kind of plays into their sport, what's driving it. So I just had her do pogo jumps, which were okay, but then we did triple hops. The biggest Trendelenburg, so her left side just boom, boom, boom down the hallway. When she jumps on her right leg, she was just leaning to the right massively. She had no clue. I go, did you tell the difference? She goes, what are you talking about? I go, let me show you something. And we shot a quick video. She's like, oh my God. And I was like, yeah, you're like leaning over your hip. Well, if her glute's all concave, maybe she can't access eccentric load through her lateral rotators, all stuff. We kind of have a postulation of what's going on. But right away, she's like, yeah, that was okay. I saw that, right? No pain though. So we get her on the table from a palpation standpoint, like spine moves awesome. She has we're talking slight decreased external rotation at 90 degrees supine. So she's on her back. I'm feeling that right hip. And then the only other thing is slight extension restriction in her hip when she's in prone. Other than that, there is nothing on like range of motion palpation. Even from a soft tissue standpoint, I would say minimal trigger points in her right glute that are different than her left. But if I was, let's say I'm doing like a global scan, like somebody has back pain and I'm looking at their hip, I would not like be like, oh, that's the thing I'm focused on. They exist, but she's also a track athlete. A lot of these things are common, right? Even though we'd say, yeah, trigger point shouldn't be there. I'd say it's common. So I'm like, yeah, we palpate, nothing refers. We don't expect a glute to refer into the anterior hip anyways. And we'll talk about how the glute's playing into this here pretty soon. So we see two minimal decreased ranges of motion. They're both soft tissue, right? Like you can feel there's a springy infield of the decrease in range of motion. No positive neurologic exam. From an orthopedic standpoint, when we do a labral scour, kind of just scoping through her hip, when you get into adduction, internal rotation, she gets a decent pinch on the inside of her hip. And she says it's a 7 out of 10. So there's our first, like, okay, go over to the left side, nothing. So, because that's common on some people that it just hurts to get in that position bilaterally. The other thing is when we test resisted hip flexion, again, from supine at 90 degrees hip flexion, I'd say it's a 4, maybe even a 3 when we're grading strength with pain. Again, a 7 out of 10 in the exact same spot. That spot, I would say, is just medial to the rectus femoris tendon. So we're in like no man's land. It's not her tendon. Because so this is my tip for you guys when you're doing this. When somebody's hip hurts, have them point to where it hurts, right? And then be like, literally keep your finger there. And then let's go in and palpate on that. And then like try to get as precise as you can. And then do the test a couple times. Be like, does it change? Does it get less? Does it get worse? We did that. And I was like, dude, that seems like it's probably in your hip, right? We can push into her hip with a labral scour. Yeah, we're resisting motion, which you'd think, oh, that's got to be a muscle, a tendon or something.
When your finger was there, you're saying having her resist and you're looking for contraction over your finger?
No. I'm just having her point and be like, where's it hurt? Going and palpating. And I'm like, well, that's not your, okay. It's just medial to your rec fem, which then you'd be like, oh, it could be pectineus, it could be all these things. I'll explain, all of these together and then like why she's having pain like that.
If you were not certain that when you put your finger there, that's what the tendon is, would you then have gone and resisted the range of motion to see if it would have changed on your finger or how?
I think you can feel a rec fem tendon.
Okay. I'm just
pretty
saying,
easy. Yeah.
If you were somewhere in the body and you had a hard time feeling if that was a tendon or differentiating it from a nerve.
Yeah. We did this in your elbow.
Yeah. That's what I'm saying.
So we were palpating around. Alex was palpating around his elbow and he's like, dude, this thing is where it hurts. And I was like, extend your wrist and you can feel contraction. Okay, that's soft tissue. That's tendon, right? That's not a nerve. That's not a bursa, whatever you want to say. Like that's pretty bar none. Where that stuff is maybe more important is smaller areas like that, right? Forearm, wrist, foot. But I'd say it's a rarity. But in here, I would say, the only thing that gets hard is like tissue orientation should lead you, right? So pectineus is basically going, medial to lateral in this kind of, I guess, superior to inferior direction. And then which direction rec fem's going. You go much deeper than that. You're bullshitting me if you're telling me what you're feeling, like from a tissue orientation standpoint.
Yeah.
unless you're Mike Leahy and then he's still bullshitting me. But that's just my 2 cents. So whatever. So right now we have what? Minor restrictions. So if we wanted to start thinking functional audits and what? ER and extension. We know we have a pain audit or 2, resisted hip flexion, which I'm not a huge fan of that one because I don't know, there's function to that, which we're going to see here in a second, versus the scour, right? Pressing her hip. I'm like, okay, I kind of like that better. So that's what I went with. I said scour first, resisted hip flexion second for pain audit. Functional audit, I have to go with what I find. So I'm not using the trigger points because in my mind, yeah, it kind of matters. We talked about the concavity of her hip. I'm going with those ranges of motion, in particular hip extension, because she's saying she has pain in the front of her hip. Mm-hmm. This is where you have to reconcile really quick. Just because you have reduced hip extension does not mean that hip flexors, right, or interior abdominal wall are short, tight, whatever you want to say. Right? You can reduce hip extension for a lot of reasons, and we're going to get to that here pretty quick. So pain audit, functional audit, treatment focus, eccentric loading and control of glute complex. Right, we have this kind of Trendelenburg with ballistic load, right? This triple hop. We see that she has a pinch on the inside of her hip. So I'm immediately starting to think that what? She is concentrically shoving, right, her femoral head into her acetabulum, which is not uncommon at all when you have that concentric load. And then when I push a little further, she doesn't like it. When she resists hip flexion, which is extremely common, so pay attention to your patients and ask them, and they'll tell you she's actually flexing her glute. So if you resist hip flexion, they will absolutely be crushing their glute into concentric load. Put your hand under somebody's hip next time you do it, and then do it, and you're like, oh God, they are doing that. Because they suck at stabilizing their hip. So the synergistic action around your hip, even though it's flexion, it's not singular, right? Even though you're laying on the table creates a base of support. What should be happening? It should stay in an eccentric load. You're flexed, right? It shouldn't have to cram down. So when she flexes her glute, what's it doing? Pushing again her femoral head into the anterior medial aspect of her acetabulum. Welcome to like a functional, and this gets into the diagnosis, in my opinion, a functional anterior medial hip impingement, right? This isn't FAIS. I don't think it has anything to do with the hardware or the fracture. She is sucking her hip up into the acetabulum the best she can because that's her compensatory mechanism. How do I also know this? That's what my hip's like. Same injury. Hip internal rotation is absolute trash, which I've had a lot more time to accommodate. I'm a different phenotype than her. And she's only less than a year out. Mm-hmm. So who knows what I had going on at that point. But like all those things exist. My diff die would be, yeah, we could call it a labrum derangement. I mean, if you're budding, right, the anterior medial aspect, you're probably bugging that labrum a little bit. Why am I not betting money on that? It's only showing up at top speed, right? It's not like she's like, oh, I have pain squatting. I mean, she just showed me she could do a top tier SMA. Perfect. She's in the weight room. So again, you got to have to, all the clinical pieces go together. So I think I have a pretty strong picture, even though it's, in my opinion, it's weak audit material. That's the thing that sucks about this. It's like you have to go with what you're given. And in this scenario, the best thing I have is like a big motor control pattern, that jump, which mimics a sprint, right? So jumping and sprinting mimic the body weight forces coming back up a single limb, just like running, which can be upwards of 8 times body weight. I think that's what she's having a hard time dealing with. Hence, it only shows up in sprinting, right? Which for sure we want to get under control before she starts long jumping or something like that. So first visit, what do we do? So yeah, there's a little bit of soft tissue stuff in her hip. So instead of going in there with a needle or stecco, I just do local vibration with the rock tape tool that we have here. Just for pure, like, hey, waking it up, getting some activity. So we have a low hertz setting for that. I do a little bit of stecco, but not heavy handed. Like, in this scenario, I'm kind of in my mind anatomically saying this is a glute min. I'm going to go on both sides of glute mid, glute med, and just kind of work that area, both, more for kind of waking up. Then we immediately go into kind of 3 months supine to both test how she can breathe, how she can stabilize her low back. She does pretty good, but there's a difference when she goes into heel taps, right? Left, she can go all the way out to complete, neutral hip. right side, she starts to lift into a little bit of lumbar extension. Again, I wouldn't say it's terrible. It's just different. And she knew it. She could feel it. So we work that. We work a little bit of breathing, which she's really good at. And then we immediately go into 5-month hip rolling on that right side. And then we end with eccentric slide plate lunges. So if you imagine she's standing, she has her right foot on a slide plate, and I'm kind of telling her to work on intra-abdominal pressure, and she's driving her foot into the ground through hip extension. For what reason? To expose her to hip extension, even though I know her pain's in flexion, but where was the limitation? External rotation extension with her glute doing some concentric load just so there's no pain. Like she's going to have to do that to sprint. So I'm going to expose it to her when her hips maybe got some more proprioceptive input in a better state, whatever you want to call it. So, and that's what I sent her home with homework, which may seem counter as we go through the rest of the visit, but it was just literally dead bugs with heel taps, being very cognizant of, what your spine's doing in that position, not going too far, make sure you're honed in on breathing, and then those eccentric slide plate lunges, because now I can give her a very clean warm up, because they're both the same thing. If I go through a heel tap and supine or a lunge, I'm working what? Hip extension, one's from flexion, one's from neutral. So both the same thing. Is everybody with me on that? So she comes back in second visit. And at the end of that first visit, hip extension and external rotation were both better, but they were minimal. So I'm like, whatever. I don't have her do the triple hop again, because do I expect that motor pattern to change? No. And if it did, I'd be absolutely amazed, but I'd expect it to be shitty again the next visit. And she's going to practice every day of the week now. So there's a lot of conflicting input that we're going to have to deal with every time she goes and runs and sprints and stuff. But again, what are we picking up also? Great kinesthetic awareness. Anything I throw at her, she's just like, poof, moves awesome. So like all of this is in our favor in terms of like how hard I can push her. So second visit, she comes in, she's like, my hip's about the same. Like she had just got done with practice. They also ran for 3 hours in the rain that day. It's the day that it poured and all the kids came in.
They ran inside.
No, they ran outside.
Oh, I thought you were.
They don't have an indoor facility.
No, I mean, I thought, well, if it rained, sometimes we ran in the hallways of the school.
No, I mean, both the girls that I saw back to back came in just absolutely soaked. I was like, you could change clothes. I mean, come on.
Yeah.
But like just water in their shoes. So
yeah.
She's just post practice. So she's about as fatigued as you can get. On this visit, for whatever reason, her SI joint was a little restricted in extension on the right side. So we adjust that. We go right back to 5 months hip rolling. Low oblique sits on that side because I'm just starting to work eccentric load, right? Not necessarily like, hey, I need to improve rotation, just eccentric load through the glute complex. 3 months supine with some like rolling to just kind of start working different patterns. We work hang position on the right to start, again, adding the foot in to kind of eccentric load through the hip complex. We add diagonal single leg deadlifts, which I knew I wanted to try to send home for homework. And this is, again, she's fatigued, but we put her into diagonal single leg deadlifts, which is Koichi Sato stuff. If you're not familiar with it, she gets to the 5th rep and she's just like shaking like there's an earthquake. Because why? I always equate it to a tight guitar string, right? Like the smallest string on a guitar is technically the tightest, and you strum it as the highest pitch. So if I have a glute that won't let go into eccentric load, that thing starts to vibrate, right? Or go into the staccato. It's not fatigue. It's absolutely not fatigue. The thing can't turn off, right? If we want to say that, it can't decontract, can't eccentrically load. So it looks like fatigue, but it's literally like, I can't get it to turn off. This is where and these guys will attest to this, I have a lot of people do diagonal single leg deadlifts on a vibration plate for this reason. We use single planar vibration on a vibe plate for what? The muscle is having to contract constantly on single planar vibration just to stay balanced, right? So basically on a vibe plate, it's moving side to side. So it's coronal plane, right? You look at a power plate, it's triaxial, and that's been proven to be a little bit much for the nervous system. So it's moving in all 3 planes when it vibrates. So you do that, the muscle's kind of having to freak out. And believe it or not, that will actually help like calm down stuff because the muscle's having to do more work. So your brain's either like, get it done, or you're either going to see what? They completely fail, like buckle out of their hip. And then you're like, it's too much. Or it like makes it a little bit easier. Mm-hmm. So it's like running interference, right? If you match tuning forks, like it's like matching a frequency. Not really, but that's kind of how I think about it. And then we retested, or we tested, sorry, not retested. So we tested single leg and double leg deceleration jumps and then rebounds, which I'm going to share a video here. So if you're not familiar, just a deceleration jump, usually off like you could start with a 12-inch box. We usually just go 20. You're just trying to jump off the box and land in a squat as quiet as you can, as soft as you can. And then rebound is what? You land and boom, you're off the ground as fast as you can. You do double leg, you do single leg. This is a good sign of what? Motor control, deceleration, the ability to generate force reflexively, not from a static position, which is basically almost every sport, unless you're in like golf or something like that. So let's see if I can share this. So I want to show you. So this is their left side. And we're not going after like just, hey, give me everything you got as fast as you can. We're just saying, hey, can you load? Because before we did this video, we did what? Double leg, single leg, stick the landing, make sure you can like be stable. And now we're like, hey, just hit the ground and give me a good load and, respond, not like as fast as you can. So this is the left side. This is the non-injured side. And I'm just going to, if it'll let me back up. So let's look at her landing. So there is a little bit of lumbar flexion, but you see how she's in really good, like eccentric load in her hip, her hips behind her heel, her knee's not driving forward. She's not going torso way crazy. Her shoulders are in line with her knees. She's throwing her hands back, getting ready to go where? Up. Now, I'm not crazy about this from an athletic performance standpoint because where does she go first? Forward, right? So she has to kind of compensate somewhere, and that's getting into her foot a little more. Everybody with me there? Mm-hmm. So again, if you were testing this, I'd be like, dude, I'd put a bar right in front of her face or a dowel, and I'd be like, nope, don't go there. And I'd see what happened. It'd be horrible because and you're going to see her foot becomes a bigger issue as we go. So that's the left side. Oh, come on. So now right side, I'll just watch it fast. So first of all, you can all tell, let's just play it a couple times. Even though we're not going fast, like that's like landing in a puddle of mud. Like she just like, yeah, right? Can't recoil. But then we go to her landing position. Look at Seth and his gray crayon scrubs. Land. Complete collapse, right? Look how far her torso is down. We could go side by side, but like now she's also towards me.
Yeah, she has one arm back.
And if I look down the line, and we're not saying that valgus knee collapse is the devil, her knee is going the opposite direction from me and her hip's coming towards me, right? Like she's trying to like move around her hip because why? She can't let her hip go back into the socket or eccentrically load very well or efficiently. You with me there? Like she could do a squat just fine. We know that. We watched her do it. She could do it with low. She does it in workouts. So now she has, and do you see what happened? It's not two arms behind her, is it? Yep. This is the key, is one, because why? She's creating a rotation around her hip, making up for sagittal plane. That left arm is like dead to the world. It's interesting, isn't it?
Yeah.
What do we also see? She's not getting any power because if she did, she'd go forward again because that's what she does. She can do it. Go back to the good side again, just so you can like watch where both limbs go. Boom. And then she's like already getting ready to launch. Like it's not perfect, right? So there's flaws on both, but now we're trying to be like, okay, you can't load. Well, I don't have video of when we did more of these last visit, but like as we got her fatigued, she absolutely just like sinks onto that right hip. And then she got very aware of it. And her mom actually said something extremely, I don't know, like she just put it beautifully at the end of the visit. I was like, hey, I want to see her 2 more times next week because track season starts the first week of March. And she goes, yeah, we got to get her to move through her hip instead of over it. So let's go ahead and do that. And I was like, yeah, okay, I should have said it like that. And her mom's in the waiting room just listening to us. And I was like, yeah, okay, I should shut up. Let's turn off share. So that was second visit and we tested that. And I wanted her to see like, okay, this is where my mind's at. This is where we got to get to. And I explained to her, hey, I know you went through this return to play criteria at PT. Did you do this? She said, yeah. So I don't know what their standards are. If it's like a height measurement, I don't know what it is. If you just look at it, I wouldn't have let her pass. I'd be like, there's something going on here. Now, do we have to get perfect? No, but I'd be like, if you're going to go have somebody sprint and triple jump, right? That's one of her events. We could see that that's probably going to be awesome. That's her also last drive foot. Yeah. All right. So third visit, which was last night. Low oblique sits. So we're kind of moving her up from 5-month hip rolling, right? We're starting to get a little higher level from the beginning. High kneeling sits, which is right in our wheelhouse now, right? We're really getting into this, the mix of coronal and sagittal plane through the eccentric loading of her hip, moving her away from how she wants to move through her hip. And then we immediately move up to oblique squats, right? Which is a split stance. And we're working on, basically moving your pelvis into adduction, abduction with rotation. From that position, wildly different, which I should have videoed. We're not huge about documenting every piece of a patient visit because it seems awkward. But she can get her pelvis to abduct, right? Roll open on that right leg, but to close it down, I literally am like sitting there. I'm like, no, like let it close down, like laser pointer on your hip, let it, all these things, put my hands on her. And she's like, it's just not happening. It's not like her hip stiff. It's just tough. So we get her in, this is where we use like, reactive neuromuscular training or R&T stuff. So we have the, physical industry strap or the Beau beard strap, because it costs $2 to make on your own instead of $100 to buy. And we wrap her up in that and give her assistance for that adduction moment. And she figures it out. And then here pretty quick, what do we see? The earthquake come back as she's doing that. And she's 3 reps in. There's no way she's fatigued. And if you go back to an old lecture on the RTP website on perturbation and what true perturbation and rehab means, we talk about what that is like meaning from a neurologic standpoint. And she's just like, oh my God, and kind of like almost embarrassed. I was like, no, it's good. Like that shows us how tough that is for your nervous system to pick up. So we go through that. We do both slings. So kind of right shoulder, left shoulder. We work a little bit of explosion out of that movement. And then we go back to D-cell rebound testing, right? Hey, after we've done all this stuff, let's just see what it looks like. And instead of I looked at the test like we just saw, and then I go, hey, let's work on this for the end, almost like a hit the save button. So she would land, and then she would mimic her oblique squat load. So she would land on her right foot, then go through almost like a single leg deadlift load. I'd have her do pelvic adduction, abduction, and then kind of come up to neutral. And then we just kind of did that over and over, where she had to do what? Emphasize a massive hip hinge. And I'm not getting into the whole knee valgosity, all that stuff yet. I'm trying to see, will that clear up? Well, I have to break it down, because when I tell her to control her knee in her oblique squat, which was part of that coaching, she does totally fine. All right. She can lock her knee into position over her foot, start moving her pelvis. It was just tough, but she got it. Mm-hmm. So that was her homework. So now it is purely homework is single leg or diagonal single leg deadlifts, which is a great warm up. Oblique squats, which is pelvic, rotation, if you want to call it that. It's all she's doing right now. And then I talked to her at the end of where we were kind of going. I go, are you kind of getting the idea where we're heading? She's like, yeah. And I think she does. And I was like, so in my mind, and this is what I put in extended plans, is we want to start patterning jumping more and more. So we could do like jump lunges, right? Where she's having to jump from 2 feet, land in a right lunge, or even transition in air. Skater jumps, like that's coming down the pipeline probably next visit, right? Body weight, pauses. We also want to start looking at coronal plane, like lateral lunges with like a throw or a catch, where I throw her a medicine ball and she has to land on that right leg in an eccentric load. Do that a bunch, then be able to do that and create concentric load. And then we start getting back to like triple jump, like not only using it as a test, but like, can we actually train that, right? Where we say like, hey, I get to clap on any one of your triple jumps. You have to pause, right? So she has to be able to load instead of just fall out of it, which is what she's doing. And then the one thing that I told her, I go, and this is a lot of my patients, so maybe I'm just biased. I'm like, you need to start jump roping, because that's going to just give you a little more pop, because we see from her left side when we test it, she's not the best at just generating vertical force. So like, I want her to just, as a sprinter, to just have like springs from the bottom up, bottom up. So I just said that's a general thing. If you want to start doing it, cool, but I'm not going to tell you you have to. But we give everybody in here at the end of care, hey, these are the things to keep working on. Not just like, oh, you're good. See ya. Foam roller your quads. Keep working on this stuff for performance. And then if you need us, we're here. And a lot of people, we do a further out check-in, like Alex's patient is 6 weeks. So with her, the timeline is I've only seen her 3 visits. I'm going to see her twice more next week. And then I told him I want to see you once a week or one time the following week. Then we're going to take a week break because you're going to be 2 weeks into track. I want to make sure you're doing okay without seeing me. Then I'll see you the following week. And then I'm literally going to say, hey, I want to see you in a month. And then after that, use me as needed if track presents with like tightness, weird stuff, just literally like, I don't know, whatever you're going to call it, like palliative care, making you feel better as you're performing a sport. That's different than treating an injury in my mind. So yeah, the breakdown is she's just kind of protecting the snot out of her hip, and she gets it. Great mover. So we'll kind of see, but I'll make sure that I video the specific things we go through this and post it either whether that's in the residency or on social media or something like that, so you guys can see the progression of this as well.
I picture in your head as you're hearing her history and seeing where you could go with this and realizing that she's only a year out from when it happened, being like, all right, this is the chance. All right, girl, we're going to get you where you go. Because I had 6 years before I'd noticed, or what?
Oh, yeah.
7,
no, I told her,
I
was like, I'm 30 years out from when I broke my leg.
Mm-hmm.
My left leg's still not the I did loaded diagonal single leg deadlifts yesterday or 3 days ago with 56 pounds.
Mm-hmm.
My left side is way different than my right. That should just be an easy move. Like just the easiest thing in the world. I run into like a hard, weird little like, it doesn't feel good. So yeah, I see that opportunity. And I use that story in her scenario as like, don't stop at like good enough. Like you got to keep going. And she's all about it. I mean, she's very athletic. And I mean, I don't know if she wants to do anything in college or anything, but like, I just know how I shouldn't say it has affected me. I just know it's way different.
Don't be like me, kids.
Yeah. Well, I just said, move up north, walk both ways to school in the snow, and your hip will probably. Yeah. All right. Any questions about the femur fracture case? And if not, we can move into general questions, and then those will just be for residency purposes. Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.